Hello everyone, hope you're doing well today. Today we're going to cover the ICECAP study. First we will start off with the study basics, and then we will delve into the background and discuss inclusion/exclusion criteria, and finish off with the RA role for the study. So ICECAP stands for Influence on Cooling Duration on Efficacy in Cardiac Arrest Patients. And we're going to talk more about cooling and cardiac arrest in the background section. And the principal investigators for the study are Dr. Matthew Greer and Dr. Daniel Nishijima. And the purpose of the study, as stated on the one-page summary, is to determine the following two objectives in each of two populations of adult comatose survivors of cardiac arrest. And these two populations are those with initial shockable rhythms and those with PEA, or pulseless electrical activity / asystole, which are non-shockable cardiac rhythms. And non-shockable cardiac rhythm means that there is a very small chance of defibrillation working. And these two objectives are to determine the shortest duration of cooling that provides the maximum treatment effect, as determined by a weighted 90-day modified Rankin score. And this score is used to determine the degree of disability in patients who've had a stroke. So patients can receive a score from 0 to 6, with 0 meaning no significant disability, 5 being severe disability requiring constant care, and 6 meaning death. And the second objective is seeing whether increasing durations of cooling are associated with better outcomes or recovery, implying efficacy of hypothermia to no cooling. Now let's take a look at the background of the study, which will better place this purpose into perspective. First, we'll begin by talking about cardiac arrest. So cardiac arrest is the abrupt loss of heart function, breathing, and consciousness. In the United States, there's more than 350,000 cases of cardiac arrest. And cardiac arrest is often used synonymously with heart attack. However, they are completely different. A heart attack or myocardial infarction occurs when blood flow decreases or stops to a part of the heart, causing damage to the heart muscle specifically. A heart attack can lead to a cardiac arrest. Now, cardiac arrest is extremely serious, and if not treated within minutes, it can lead to death. The treatment for cardiac arrest typically involves either cardiopulmonary resuscitation, or better known as CPR, or defibrillation. Most cardiac arrests are caused by a heart's electrical system malfunction, which leads to arrhythmia, which is abnormal heart rhythm. Although in some cases this can happen in individuals who have no known heart disease, usually arrhythmia develops in a person with a pre-existing or underlying heart condition, such as coronary artery disease or congenital heart disease. And there are several risk factors for cardiac arrest, and these risk factors are very similar to the risk factors of coronary artery disease, since coronary artery disease can lead to cardiac arrest. Now, the risk factors include a family history of coronary artery disease, smoking, high blood pressure, high blood cholesterol, diabetes, and obesity. In addition, other factors such as age, previous heart attacks or cardiac arrest, or nutritional imbalance can also increase the risk of cardiac arrest. Now that we've talked about what cardiac arrest is, let's now talk about what happens after treatment. If the CPR or defibrillation is successful, then ROSC, or return of spontaneous circulation, is achieved. Now, ROSC is the resumption of a sustained heart rhythm. Some signs that ROSC has been achieved includes breathing, coughing, and movement from the person who has experienced cardiac arrest. If ROSC is achieved, then the individual has a palpable pulse or a measurable blood pressure. Some individuals regain consciousness after ROSC. However, some individuals, even after ROSC is achieved, might not regain consciousness and enter a comatose state. When a cardiac arrest occurs, there is reduced blood to the brain, which can cause brain damage. Therefore, to improve outcome for patients who are in a coma, they are cooled soon after their cardiac arrest. And this process is called therapeutic hypothermia, which is also known as targeted temperature management. Targeted temperature management is a treatment used in unconscious patients with spontaneous circulation and has been shown in previous research studies to improve the outcome of these patients. There are multiple potential mechanisms that have been outlined that show how TTM prevents neuronal cell death. One is that by cooling, it reduces the cerebral metabolic rate, which reduces the demand for oxygen in brain cells. Another is that the cooling can decrease the inflammatory response caused when the brain might be initially damaged soon after the cardiac arrest. The procedure for TTM can be divided into 3 phases. First, we have the induction phase, during which the goal is to achieve a core temperature of 32 to 34 degrees Celsius as soon as possible. Then there's the maintenance phase, where this temperature is held for 12 to 24 hours. And the final phase is the rewarming phase, where the core temperature is gradually raised by 0.2 to 0.5 degrees Celsius until the core temperature is greater than 36 degrees Celsius. Although previous studies have found that this treatment is successful for out-of-hospital cardiac arrest, the effectiveness of this treatment is still around 50%. Therefore, this study is trying to learn more about the treatment overall and potentially implement new procedures to improve the condition of patients who receive this treatment. Now that we've learned a little bit of the background regarding the study, we will now look at the inclusion and exclusion criteria for ICECAP. So this is the inclusion criteria, and all of these criteria have to be met for the patient to potentially be eligible for the study. And the inclusion criteria is as follows. So the age inclusion is that the patient has to be 18 years of age or older. They have to be in a coma after resuscitation from a out-of-hospital cardiac arrest. The temperature of the patient has to be less than 34 degrees Celsius within 240 minutes of cardiac arrest, and they have to have a definitive temperature control device applied. In addition, we also have to have informed consent from the LAR or legally authorized representative, including intent to maintain life support for the patient for 96 hours. And the last inclusion criteria is that we have to enroll the patient within 6 hours of initiation of cooling. And to sum up the inclusion criteria, we're looking for any patient greater than or equal to 18 years of age who's had a CPR before presenting to the ED and sustains ROSC, which is return of spontaneous circulation, and the patient must be cooled within 240 minutes of cardiac arrest via a definitive temperature control device. This is the list of the exclusion criteria, and if any one of the exclusion criteria is met, then the patient is not going to be eligible for the study. The first exclusion criteria is that the patient has hemodynamic instability, which means that there is an abnormal or unstable blood pressure, which can cause insufficient blood flow. In most cases, this will require artificial or mechanical support to maintain blood pressure, and these devices are what are listed in the parentheses. So ECMO ventricular assist devices IABP are all mechanical devices that bypass or assist the heart in order to maintain blood flow. The second exclusion criteria states that patients with pre-existing conditions that confound outcome determination will be excluded, and these conditions can include sepsis or pre-existing neurological disability. The last exclusion criteria states that the patients with pre-existing terminal illness will also be excluded. This includes patients with cancer or a DNR, or do not resuscitate orders, which will exclude them from taking part in the study. So now we're going to discuss the role of the RA for the ICECAP study. Now, for this study, only the investigators are allowed to consent. Therefore, our primary responsibility as an RA will be to screen for eligible patients and then report to the RC or ED providers regarding the patients we found who are eligible. When screening for ICECAP, we're going to be looking at the following two chief complaints for patients who are coming in. The first one is 944, which is a medical emergency, and the second one is ROSC achieved. In addition, we can also be looking for a banner of CPR or 944 on the EMR chart. When we find an eligible patient or potentially see one of these chief complaints, we can also look at the SHORE report label to get more information, such as the ED triage notes about the patients before entering a patient's chart and filling out a quick disclosure. When we do enter a patient's chart, we can click on the narrator tab to find the time of cardiac arrest, time of cooling, and if the patient has hemodynamic instability. Now let's talk about when we should be screening for ICECAP and who we should report to if a patient is found to be eligible. Now, RAs can screen for ICECAP whenever they are in the ED. If the RC or JS is on shift when an eligible patient is found, we would alert the RC or JS even if the PIs are not on shift. Now, if the RC or JS is not on shift and an eligible patient is found, then we would talk to the attending physician of that patient and ask to see if the ICECAP team has been alerted. So if the attending physician is busy, then we would ask the resident to see if the ICECAP team has been alerted about the potential eligible patient. The treating team are going to be the ones that always calls Dr. Greer or Dr. Nishijima directly. Even if they are not working on shift, they are going to be alerted about a potential patient. Therefore, RAs should not be calling either PI to notify them unless asked to do so by the attending physician. That concludes the overview of the ICECAP study. Thank you so much for watching and have a wonderful day.